Hi, this is E. David Crawford, Editor-in-Chief of Grand Rounds in Urology. I'm excited to launch today a new series called the Asian Series, where Dr. Peter Chiu, who I'll introduce in a minute, is gathering information and comments from his colleagues around Asia to share with our Grand Rounds in Urology audience. There are a lot of things that are happening around Asia, and they're a little bit different than things that occur in the US, and we're happy that Peter has agreed to be the associate editor for this. Peter graduated from the Faculty of Medicine of the Chinese University of Hong Kong. He did a fellowship in urology at the Royal College of Surgeons in Edinburgh. He received postgraduate training in prostate cancer research at Erasmus Medical Center in Rotterdam. And he got his PhD on a thesis on optimizing prostate cancer diagnosis in Asian men. He's very well qualified. He currently works as an associate consultant and honorary clinical assistant professor in the Prince of Wales Hospital at the Chinese University of Hong Kong. And we're very grateful, Peter, for putting forward this effort of bringing this education to us. I've had the opportunity to visit with him a couple of times in Hong Kong, and he has an outstanding facility and faculty and group that he works with. So, Peter, thank you very much for being part of Grand Rounds in Urology.
Hi, everyone. This is Dr. Peter Chiu, a urologist from the Chinese University of Hong Kong, and welcome to the first Asian series of Grand Rounds in Urology. And starting from today, we're going to have a list of Asian experts, mainly urologists, to talk about important urology topics from an Asian perspective. And today we're honored to have Professor Yao Zhu to tell us something about the genetics of prostate cancer. So Professor Yao Zhu is an attending urologist at Fudan University, Shanghai Cancer Center, and an associate professor in oncology at Shanghai Medical College. He received his MD degree from Fudan University in 2006. And after completing the internship, he started his residency at the Department of Urology, Fudan University Shanghai Cancer Center. He's a board-certified urologist in China, and his practice focuses on managing urological malignancies. He's involved in several multi-center clinical trials and investigator-initiated clinical trials in genitourinary malignancies. And his research is supported by multiple grants from the National Nature Science Foundation of China. So without further ado, Professor Zhu, please. Thank you.
Thanks, Peter. So hello, everyone. Glad to have this opportunity to discuss epidemiology and the genomics of prostate cancer in Asian men. I'm Yao Zhu from Department of Urology at Fudan University, Shanghai Cancer Center. We know prostate cancer is a disease with remarkable geographic difference. Asia is traditionally considered as a continent with lowest incidence. For example, the age standardized rate of prostate cancer in East Asia is 13 per 100,000 males in 2018. The data was only 1/6 of the highest incidence region as North America. Interestingly, the prostate cancer incidence rate varies as many as 5-fold across different regions of Asia, with the greatest value in the Western Asia and the lowest value in the South Central Asia. In contrast, there was less variations in the mortality rate between different regions. We know Asia contains almost 60% of the world male population. Although the incidence and mortality rate was lower in Asia, the huge number of new cases and huge number of new deaths was diagnosed every year. In 2018, nearly 15% of the new prostate cancer were diagnosed in East Asia. Meanwhile, we can see 19% of the new deaths occurred in East Asia. The number of deaths was twice the number from North America. Prostate cancer incidence and mortality rate may be influenced by the geographic location, socioeconomic status, and other risk factors as obesity. We evaluate the associations between these factors and the epidemiological features of prostate cancer in Asian countries. We found prostate cancer incidence was significantly associated with the Human Development Index. The Human Development Index is a composite measurement of life expectancy, education, and GDP. But the mortality rate didn't associate with the Human Development Index. Interestingly, we did not find an increase in prostate cancer incidence or mortality along with the higher obesity rate across Asia. One possible explanation was the significant difference in obesity prevalence among Asian subregions. For example, countries from Western Asia have a high rate of obesity. Meanwhile, countries from Southeast Asia had a much lower rate of obesity. We can see a strong correlation between mortality to incidence ratio and the Human Development Index. The mortality to incidence ratio reflects the survival rates after cancer diagnosis. Early diagnosis and better cancer treatment may explain the increasing survival in highly developed countries. And another interesting point is significant geographic difference in the Asian continent. In highly developed Asian countries as Korea, Japan, Cyprus, and Saudi Arabia, we can see widely variations of cancer incidence from highest in Cyprus to the median level in Korea and Japan and the lowest date in Saudi Arabia. These differences highlighted epidemiological features are not one size fits all in the Asian continent, and we need more data to evaluate these differences. The difference in epidemiology also provide a huge opportunity to investigate the underlying difference in the carcinogenesis and tumor progression. Nowadays, we have accumulative evidence to stratify prostate cancer into molecular subtypes, and most importantly, we can treat these patients with different potential effective drugs. The prevalence, however, was mostly based on the data from the Caucasian population. We can see the most common somatic alteration in Caucasian prostate cancer patients is TMPRSS2 ERG fusion, accounted for nearly half of the disease from the Western countries. In a 2018 review of prostate cancer, they found the frequency of ERG oncoprotein was less than 22% in the East Asian patients, and the low rate of TMPRSS2 fusion was further confirmed in a prospective clinical trial of AKT inhibitor in metastatic CRPC. The biomarker analysis showed a 15% of prostate cancer had a tumor fusion in the East Asian population. However, the rate was above 13% of cases from other countries. Interesting, we can see the rates of ERG positive was similar between incidental and metastatic cases from Japan, suggesting that the low rate is not explained by the PSA screen and is likely an inherent feature of disease in East Asian men. The rate of PTEN loss was also lower in the Chinese prostate cancer cases, even though the Chinese patients had a more higher Gleason score disease. In this head-to-head comparison study, we can find the rate of PTEN loss was less than half of the patients from United Kingdom. The finding was also confirmed in the prospective clinical trial of AKT inhibitor. Since PTEN loss is associated with the response to AKT inhibitor, so lower rate of PTEN loss in East Asia patients may impact target therapy drugs trial. The table here, we summarize the rate of genomic alterations between different studies. Since these genes are not compared head-to-head using the same analysis platform, this difference should be interpreted with caution. However, we can find some interesting clues to further validation. We found a high rate of SPOP mutation, CHD1 deletion, BRCA2 and CDK12 deletion in the Chinese prostate cancer patients. And these are all potential drug targets and need further validation in large studies. And in the most recently study, using very comprehensive genomic analysis data, we can find another interesting gene in the East Asian population. FOXA1 is a key gene in androgen receptor-mediated gene regulation. And in this research from China, the researchers found 41% of the localized prostate cancer had a FOXA1 mutation, much higher than the data from the North American series. Furthermore, the mutation occurs in a hot spot and mutually exclusive with ETS fusion and strongly associated with upregulation of androgen metabolism genes. These information in together suggested a specific carcinogenesis role in the prostate cancer in China. And briefly summarize the impact of genomic changes in Asian men. From these data in the tumor sequencing, we can see the low rate of ERG fusion may decrease the diagnostic performance of ERG fusion kit, and the low rate of PTEN deletion may decrease the use of AKT inhibitor in clinical trial in the Asian population, and the high rate of CHD1 deletion and the BRCA2 mutation in East Asian population may increase the use of PARP inhibitor in clinical practice, and the higher rate of FOXA1 mutation and the SPOP mutation, which is strongly related to the androgen receptor regulation, may increase use of intensive androgen deprivation therapy in our patients. And another interesting, besides the tumor genomic change, is the Germline mutation and the single nuclear polymorphism in the Asian population. Since most of the GWAS study has been performed in men of European descent, Asian men only account 11% of all GWAS study, despite our population accounted for 60% of the global population. And we can see until now, more than 100 SNPs were identified to explain nearly 30% of the family risk of this disease. However, only 11 of these SNPs was initially identified from GWAS in the Asian population. The authors have validated the 11 Asian-derived SNPs in a huge number of men from the European descent, and we can see only 3 SNPs achieved GWAS significance, and this data suggested the role of genetic background underlying the ethnic differences. However, the germline mutation rate of DNA repair genes was quite similar between Caucasian and the Chinese patients. Both studies reported around 10% of the high-risk prostate cancer patients had germline DNA damage repair gene mutations. HOXB13 is a gene associated with prostate cancer risk in European descent. However, the 2 studies from Chinese and Japanese patients didn't detect the recurrent mutation site in East Asian patients. Another interesting point is the difference in the pharmacogenomics of prostate cancer, especially in the testosterone metabolism pathways. There are several key enzymes and transporters in the process of testosterone metabolism. For example, HSD3B1 regulates the conversion from androgen precursors to the potent androgens, and men from East Asia carry a lower probability of active HSD3B1 alterations. In prostate cancer patients, the active HSD3B1 change was associated with a poor outcome during conventional androgen deprivation therapy. However, it may associate with a better outcome after abiraterone treatment. So the low rate of active HSD3B1 alteration in East Asian men may possibly explain the relative better outcome of androgen deprivation therapy in this population. However, these data and these interesting points need further validation in prospective multicenter studies. In summary, we need Asian-specific genomic models to diagnosis, prognosis, and predictive in clinical practice. And the similar germline DNA damage repair mutation rate suggested we should propound genetic consultations in East Asian patients. At last, we have some take-home message. In our preliminary findings, we can see there are significant variations in the epidemiology and the genomics features of prostate cancer among Asian regions and countries. And we found ERG fusion positive prostate cancer rates was relatively low in East Asian men, and the FOXA1 mutation was more commonly found in Chinese localized prostate cancer. And the genetics alteration revealed remarkable different gene polymorphism between men of Asian and European descent, whereas the germline mutation rate of DNA damage repair genes was comparable in the two different populations. And interestingly, we can see the pharmacogenomics of testosterone metabolism-related genes revealed an inherent difference in Asian men versus Caucasian men, and possibly provide a potential explanation for the difference in the androgen deprivation therapy. And we are seeing more data and more studies to evaluate different aspects of this difference. So thank you. Thanks for the opportunity to give my talk, and hopefully we can have more discussion in the future. Thanks.